Hello everyone and welcome to today's program, the CDI Perspective on PSI, More Than Just Quality of Care, part of CDI Week and ACDIS's celebration of the CDI profession. My name is Chery and I'll be your facilitator for today's webcast. Our program will be 60 minutes in length. The first portion of the program is presentation, followed by a question and answer session. Today's program is being recorded. Before we get started, I'd like to take a moment to review the web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, if you're listening over the internet, please adjust your computer volume settings. Third, to submit a question, go to the chat pod located in the lower left-hand corner of your screen. Type your question in the text box, then click the Send Message button. You may submit questions at any time during the presentation. However, please note that it's likely that your question will not be answered until the Q&A portion of the program. Should you have any technical difficulties during today's program and need assistance, please type your inquiry into the chat pod or call our tech support line at 877-297-2901. Next, I'd like to introduce your host for today's program, Brian Murphy, CPC. Brian is the Director of the Association of Clinical Documentation Improvement Specialists, the nation's only dedicated association for the CDI profession. He oversees the association, including management of its award-winning web-based resources and other products, certification, boot camps, and the annual conference. He also leads association outreach and develops industry CDI guidance in conjunction with the ACDIS Advisory Board. And now I'd like to turn it over to you, Brian.
Okay, great. Thank you very much, Chery. I want to just take a moment to welcome everyone to our 4th annual CDI Week. I hope you're all having a great week and enjoying the resources that we have to offer. As a reminder, the theme of this year's CDI Week is CDI and Quality, Transforming Healthcare. And we're certainly pleased to present today's free webcast in that same vein. As mentioned by our facilitator, this program is being recorded, and we will be uploading it next week to the Toolkit page of the CDI Week tab on the ACDIS website as a permanent resource for you to listen later. So now I'd like to introduce today's speaker. We have with us today Cheryl Ericson, MSRN, CCDS, CDIP, and a HEMA-approved ICD-10 CM-PCS trainer. Cheryl is the Associate Director of Education for ACDIS and the CDI Education Director for HC Pro, a division of BLR in Danvers, Massachusetts. Cheryl is responsible for the development and revision of CDI bootcamp content and serves as the lead trainer. She is a CDI subject matter expert for a variety of HC Pro and ACDIS publications, as well as serving as an advisor on a variety of initiatives that affect CDI professionals. Prior to joining HC Pro, Cheryl managed clinical documentation integrity, core measures abstraction, and utilization review departments at a large academic medical center. She has an extensive background in adult education, data analysis, healthcare revenue cycle, and CMS guidelines. Welcome, Cheryl.
Thanks, Brian. I'm glad to be here.
Okay. So before we get started, if you look on the left side of your event window, you will find a Handouts tab where you can find a copy of Cheryl's slide presentation today. And please feel free to print that for reference if you don't have a copy already. We've also included with that a certificate of attendance. And also as a reminder, this program does offer a free CCDS credit. And if you're interested in obtaining this credit, we ask you to please download the instructions from the Handouts tab on the left side of your screen. So with that, I'm going to turn it over to Cheryl to start today's presentation.
Okay, thanks again, Brian, and welcome everyone to CDI Week. I'm glad to see there was so much interest in patient safety indicators, and hopefully this is going to give you an opportunity to learn a little bit more about patient safety indicators, in particular PSI 90. I think a lot of us in the world of CDI, we're understanding that the relevance of assigning codes especially when we're representing diagnoses in the health record, it's continuing to evolve. Prior to 1983, it was for statistical purposes, and then it became important for reimbursement methodology. And now that CMS has their initiative to pay for quality, healthcare data is being interpreted, or it's the de facto measure of healthcare quality. So with the changing role of coded data, it places greater significance on the impact of an organization's data because it can both directly and indirectly affect reimbursement. And most of you on the call, if you have a CDI background or are familiar with CDI's role, then you know how we directly impact revenue through MSDRG assignments, but we can also indirectly affect revenue through our coded data and our quality measures. So we're going to focus particularly on the PSI quality measures. And so PSI stands for Patient Safety Indicators. If you have a clinical background or just working in a hospital setting, you might have seen every year they put up different posters about patient safety. Now, these were developed by the Agency for Healthcare Research and Quality. That's what AHRQ stands for if you ever see that acronym. In particular, because it's a very large field to talk about patient safety indicators, and as I said, these are very important to bedside care, and so nursing staff, medical staff are very aware with these in general. We're going to focus on a composite indicator that was specifically created from several of the PSI individual measures, which is called PSI 90. And the reason why we're going to focus on PS 90 is because this is a quality measure that falls into 3 different CMS quality initiatives. That's a huge impact when you think about it because there's 3 different ways a hospital can be affected by this data. But the way the hospital is affected is different in each of these programs. Now the first bullet you're going to see Hospital Acquired Conditions Reduction Program. Some of you may think that's a typo because you might be familiar with the HAC program, Hospital Acquired Conditions, and that's related to present on admission. But in fiscal year 2015, CMS is adding an additional HAC program which is called the Hospital Acquired Conditions Reduction Program. So it's HACRP. There's also hospital value-based purchasing. Now this has been around for a couple of years, so you might be a little more familiar with this. And it becomes a measure, PSI 90, in fiscal year 2015. And lastly, it's a measure in inpatient quality reporting, or you might see it hospital inpatient quality reporting. And that began in fiscal year 2014. So those are the different kind of quality initiatives that are going to be affected by PSIs, and PSI 90 in particular. Now PSIs are a set of quality measures that uses hospital inpatient discharge data to provide a perspective on patient safety. If you're already in the role as a CDI specialist, you know that a lot of times what's in the medical record and what gets represented in coding are 2 different things sometimes. And so I've got a citation for you down here at the bottom from a book by Maribeth, I hope I say her name right, but Farquhar, about patient safety and quality. And she's talking about the whole purpose of having patient safety indicators is to identify problems that patients experience through contact with the healthcare system. I know one of the frustrations sometimes that people with a clinical background have when they're in the role of CDI is they're like, how do I affect patient care? Well, the impact on quality metrics and making sure that we're accurately representing what's going on with the patients is a way that we can affect patient care, because if there's a problem and we're able to identify it and change processes as a result, then that's a huge impact that you can still have in the role of a CDI. So the type of problems that are identified then through quality measures could be hospital complications or adverse events. Now oftentimes as a CDI, when we see the word complications, we think of complications as kind of a good thing in the way, because we've got our CCs and we've got our MCCs, major complicating conditions and complicating conditions. But when physicians see the word complications, that usually upsets them a little bit because they think of it as a negative, and here's why. Because they're identifying hospital complications, and these are things that we're looking to avoid. The other thing, that word adverse events, a lot of people are familiar with that terminology because you don't want adverse events, or sometimes people equate these with sentinel events. These are very negative things. If your organization is affiliated with Joint Commission, you know that you try and avoid adverse events. So when we're looking at our PSIs then, these were developed after a comprehensive literature review by AHRQ, an analysis of ICD-9 codes, review by clinician panels, so they did have some physician input. Although once you start explaining these to physicians, a lot of them will disagree that they ever had any physician input. I also want to note that your PSIs are risk adjusted. Now these risk adjustments though isn't necessarily the same way as a complicating condition or major complicating condition would risk adjust. So they are risk adjusted by DRG, so your DRG assignment, and so that can have an impact. They're modified by comorbidities that are indexed on a particular list. Age is a factor. So keep in mind when we're talking about these PSIs, they only apply to those age 18 and older, so it's the adult population. But also keep in mind that we're not consistent in how we define adults in terms of coding. What I mean by that is when we look at things like RV codes right now for obesity and we're looking at BMIs, that only applies to people age 21 and older. So when we're looking at quality measures, it's for age 18 and older. They also vary by gender, and then there's some age-sex interactions that occur as well. So it's helpful to know what are these factors that impact it, even though some of them aren't things we can affect as CDIs. Now, one of the really important things to understand about AHRQ is it's software driven, and it's going to be based on administrative data. Administrative data is basically your claims data. These are your patient demographics like age and gender, which are risk factors, as well as your diagnosis and procedure codes. And so that's why we're seeing that the role of CDI is expanding beyond just direct reimbursement, which is the MSDRG assignment, because those same diagnoses and procedure codes can impact the quality ranking of an organization. PSIs have been around since about 2003, and there's 27 different types of PSIs, and they're defined by two levels. Broadly, they're either defined as the provider level or the area level. And so I need to get an idea of how familiar are most of you guys with PSI. So Brian, do you mind asking them our first polling question?
Sure, Cheryl. So in a moment you will see the question and the possible answers appear on your screen. We ask that you please select the appropriate answer using the radio buttons on the left side. You may select your answer at any time while I'm reading the questions, and your results will appear along with those of the entire audience. So now for the polling question. It reads, are you familiar with Patient Safety Indicator 90, i.e. do you know which indicators are used to create this composite measure? And we ask you to please select one of the following: yes, no, or I don't know. Again, are you familiar with PSI 90? Yes, no, or don't know. And I thought, Cheryl, while we're waiting for these responses to come in, and they are coming in quickly, you know, just as a general comment, with all the focus these days on quality metrics, is this in general the next step for all CDI departments, or is it an area that they might wish to grow into but may not?
You know, I really think it depends on the organization. We've got some places that have just started the CDI initiative, and you know, one of my pet peeves is calling it a CDI department, you know, not a program. And so some CDI departments are just now finding their way and being launched, but there's other CDI departments that have been successful for a long amount of time, and they're kind of looking for that next thing. And so I would think of quality measures as maybe that next great thing, that other way you can help impact. And the cool thing about quality metrics is it often engages physicians better than it does when you talk about reimbursement and so forth. So it's a great way to get physicians involved and caring about what you're talking about and what you're doing, because it affects patient safety.
So when are you going to show us the results? Here we go, Cheryl. We've got 33% yes, 54% no, and 12% don't know. Any thoughts on that?
Wow. You know what? I am, and I'm not surprised. I guess I'm more surprised that a third of people are familiar with PSI 90 rather than so many people not being familiar. And again, that's because this is an emerging area. If you're not familiar with it, don't beat yourself up. You know, you probably have plenty to keep you busy doing the traditional role of CDI. But we're just hearing that a lot of CDIs are being told, well, since you're in the record, why don't you go ahead and do this or that? And that's why we wanted to share information with them about quality so that they're better able to understand what might be asked of them in the future.
All right, great. Thanks, Cheryl. I'll have you
Mm-hmm.
pick up from here then.
Sure. So moving on then, now that we see that only about a third of us are familiar with PSI 90, let me show you the individual PSIs that compose PSI 90 again, because this is called a composite measure. So there's 8 individual PSIs that are going to be interpreted as a total ratio. So you can see in this graph then those things, those components that are going to make up these PSI 90, these individual components. Now remember that the target population is Medicare fee-for-services beneficiaries discharged from a short-term acute care hospital setting, those who are reimbursed under the inpatient prospective payment system. And I'm going to talk a little bit more in depth then about each of these different specific PSI indicators. Now, PSI 90 was developed by AHRQ. What's a little confusing sometimes is if you go to the AHRQ website, you're going to notice that the elements they have for PSI 90 look a little bit different than the ones I just showed you. The reason why that is that CMS is only using those patient safety indicators that have been endorsed by the National Quality Foundation, NQF, the National Quality Foundation. And that gives a little more credence to the measures that they're using. So by looking at this table, the ones that are bolded out, PSI 9, PSI 10, and PSI 11, those are included in AHRQ's PSI 90, but not for the purposes of CMS. That should be a huge sigh of relief for a lot of people, because you'll notice that PSI 11 is postoperative respiratory failure rate, or PORFs. That's the acronym for it. And we get questions all the time with people wanting to know about PORFs and how do you identify them, and then we've got the confusion between the acute respiratory failure and the acute respiratory or the acute respiratory insufficiency following surgeries and so forth. So those that are highlighted, grayed out on this graph, are not included in PSI 90 for the purposes of CMS quality measures. That's why if you follow the graph over to the columns with the numbers, you'll see those numbers are zeros, because those individual PSIs do not impact the score for the PSI composite for the CMS quality programs. Okay? Hopefully everybody's got that. The ones that are grayed out will not be used for calculations for the CMS quality measures. That is not part of CMS's PSI 90. So there's also going to be some differences that you're going to see, because there's 3 different quality initiatives that use PSI 90. Don't expect that your organization is going to have the same score in each CMS quality measure. There's going to be differences because of the type of software that's being used. AHRQ has updated their software, and they have a version 4 and a version 4.5.A. So some of them, like IQR, the inpatient quality reporting, is still using the version 4.4. But the HAC RC is using version 4.5A. We're also going to see that there's a difference in performance period. And your performance period is that time where the information is being taken from. And then there's differences in the number of diagnoses and procedure codes that were used when calculating the measures. And that can create a difference in the data as well. So on this slide, if you see the purple box that's highlighted, you'll see that when we're looking at the HAC reduction program, which is that new type of HAC program that we're seeing, it's the HAC reduction program for fiscal year 2015, your PSI data was taken from July 2001 through June 30th, 2013. Now that's going to shock a lot of hospital administration if they get penalized for this measure, because the data is already come and gone. There's no way to impact the data at this point in time. You'll notice for hospital value-based purchasing, that's the one at the very bottom. For fiscal year 2015, hospital value-based purchasing, or HVBP, easy for me to say, that its timeline was a little more narrow. It was October 15, 2012 through June 30th, 2013. So most of your time periods have already occurred, which means the sooner that you start addressing these, if this becomes an initiative for the CDI department, the better, because a lot of the data collection has already occurred, and the consequences are going to be implemented soon. When I was mentioning the difference in diagnosis and procedure codes, I want to point out that your fiscal year 2015 HAC recovery reduction program is going to be based on using 25 diagnoses and procedure codes. That's the newer type of electronic claims that we use, where IQR is still based on the previous model where there were only 9 diagnoses and 6 procedures. The concern is that you may have a difference in your PSI ratings between IQR and HAC reduction program, because with more diagnoses it might increase PSI events, therefore increasing the rate. Or it could exclude more discharges from the denominator, which could also increase PSI rates. So don't expect to see the same value. You could be a winner in one program and a loser in another program, which is going to, again, make this all very confusing. So as CDI, the big thing that you want to be aware of is what's going to be impacted by it and why is it going to be impacted. Now your quality departments have monitored your patient safety indicators since their induction in 2003. The composite of PSI 90 is relatively new, but usually your quality department's pretty familiar with it, as are a lot of the physicians. Now your PSIs are going to be, instead of affecting just your IQR, which is your hospital inpatient quality reporting, it's also going to affect your HAC reduction program and hospital value-based purchasing. But the key here is that the data is based on claims data, coded data. And so documentation is what drives coding. So you want to look at each CMS quality initiative for the specifics on each potential incentive and or penalty, because it would take me more than an hour to talk about it. But roughly what we're seeing in hospital value-based purchases for fiscal year 2015 is 1.25%, and then the percentage for HAC can be somewhat different from that. So as previously stated, our AHRQ quality indicators are going to be taken from administrative databases, and this is your coded data. They're considered a byproduct of care delivery. Just like our reimbursement to hospitals and physicians, they're going to give us demographics on the patient, the provider, by giving us diagnosis codes and procedure codes, and information about the admission, like when it occurred, discharge dates, and things like that. So the way that the quality indicator codes were determined, and there's a great frequently asked questions site that's available. I do want to let you know that this was answered in February of 2011, which means things might have changed since then, because we're starting to see more interest in quality data and the disconnect between the codes that we have available to us and quality. So hopefully some of these FAQs will get revised. But anyway, it says that the reason why they're using codes is that administrative data has the advantage of being populated by professional coders that use a common set of practices and guidelines, which brings some uniformity to the data that could be lacking in clinically abstracted data. See, that's normally how these measures were reported. Your hospitals are familiar with reporting their PSIs through the quality abstraction department. And usually that's a post-discharge process, 30 to 60 days following the discharge process. So instead, this is going to become a faster process because we're going to use claims data. Now do keep in mind that there are a number of drawbacks to using administrative data, and despite the large number of ICD-9 codes and the implied detail, they don't have operational clinical definitions. And this what frustrates a lot of CDIs with a clinical background as well as a lot of physicians. And this is why we might see some variability in code assignment, because I like to tease, if you ask 5 coders the same question, you might get 5 answers. Now the same is true if you ask 5 CDIs, you might get 5 answers too. So I'm not just trying to pick on coders. But the fact is there's still a lot of subjectivity in what we do. But I think hospitals are going to become more concerned when that subjectivity can negatively affect their patient care status. How well are they giving their quality of care? And that's where it's going to become a big deal, not only for the reimbursement but the reputation. Now, coders are generally formally trained in coding methods and instructed to use terminology in the medical record, but clinicians don't use the same terminology. That's why we have the CDI profession. And so the meaning of codes without clinical context or without considerations of disease progression can often give an inaccurate clinical picture, and that limits the usefulness of the data. So there's limitations with ICD-9 data, but this is what we have to work with. So what we want to do is make sure we have the best and most accurate documentation to support code assignments to really represent our quality of care accurately. And that's why we're seeing CDI departments potentially becoming involved in this area. So the limitations include, with using administrative data, include the clinical accuracy of discharge-based diagnosis coding. We know sometimes we get this wrong. Sometimes you have to go back and you have to query the physician for clarification. We have to find out what was actually going on with the case. Or sometimes one coder interprets it one way, CDI or another coder interprets it another way. Or sometimes the physician sees the different codes on there and they're like, that's not what it's supposed to be. And we also have some indicator discriminatory power. So administrative data is unlikely to capture all cases of a complication, regardless of preventability, regardless of being able to prevent them, without false positives and false negatives, because the codes themselves are just not as sensitive and specific as we need. Now you might be saying, oh, well, ICD-10 is going to fix this. Well, yes and no. ICD-10 is going to fix some things, but we're still going to have a lot of confusion, especially because once we start using some of the complication codes in ICD-10, we don't have those clinical operational definitions. And so there's going to be variabilities of when people report them versus when they don't. And how do you know that you're reporting them accurately? So I think there's going to be a challenge when we migrate to ICD-10. We might have some more specificity, but we're also going to have a period of adjustment for that. And again, this is why we're seeing the role of CDI expand to an awareness of those diagnosis and procedure codes that are associated with quality measures like PSI 90, so that you're able to verify the accuracy of the coded data in capturing the provider's intent. You know, we know that coders have great experience in coding the record, and they've traditionally queried. They've done a lot of the querying. But truly, if you've got a decision about querying for something that is going to impact reimbursement versus that might just impact quality, well, maybe that quality query is not going to be as high of a priority. It all depends on the mission of your coding department, of your CDI department, and so forth. So somebody has to make it a priority for these types of queries if they are going to be a priority for CDI and our coding department, to make sure that they have the documentation to match what the organization feels like they are as a performance for their quality indicators. I also, though, want to give you some caution that when you expand CDI, it can often cause competing agendas. And what I mean by that is, in terms of CDI, we want to see things like acute respiratory failure, which can add an MCC but could also lead to a postoperative respiratory failure quality indicator, a PORF. And we like to see these different complications because they're usually CCs or MCCs. However, they can negatively impact the organizational metrics for quality and the reputation of the organization. So we have to make sure that we're very ethical in our approach. Also, we have to remember that how you approach a provider regarding quality issue is completely different than how you would request for documentation. See, normally when we're asking a question to the provider about clarification in the documentation, it's not to judge them. It's not to say, hey, you did something wrong. But if we start querying in regards to quality of care issues, then we might be implying they did something wrong. So you want to make sure that you've got some clear guidance and involvement from compliance and the medical staff about how this process is going to occur if CDI does become involved in this process, to make sure that everybody is comfortable doing it. You don't want to jeopardize the relationship between the CDI staff and the medical staff by having them ask these sensitive questions about quality issues if there's a better way to go about it. So it might be that the CDI staff refers them to the quality department who've already been asking these questions. Also keep in mind that querying is a very heavily regulated process, and so we're not allowed to influence the provider when we're asking them a query. They have to have the freedom to deny or to disagree and to make their own conclusion. So you have to be careful about allowing quality folks to ask the physicians questions, because sometimes they can do it in a very directive type of way. So there has to be that happy medium and keeping an idea about the restrictions of querying when we ask these types of questions. So from this handbook for nurses, you can see that incomplete reporting is an issue in the accuracy of any data source, especially when physicians might fear adverse consequences as a result of full disclosure. Nobody likes to tell on themselves. So the heterogeneity of clinical conditions included in some of these codes make it difficult to identify complications. See, the thing is that I always like to tease it's the fox guarding the hen house. If I ask a question of the physician about a quality issue or a potential quality issue, because I'm thinking there's a relationship between two things like an infection and a PICC line or something like that, well then I'm actually looking for a complication code, and that could end up being a quality issue. But I can only code it if I have specific documentation because of the way that complication codes are set up within the coding structure. So if the physician decides not to answer that query, what are my repercussions? I'm not supposed to prod or prompt the physician. And so they have to have the right to be able to say, I don't agree, which means you've got to have another process in place then to escalate these things. Is it a pattern of habit from the provider? How are you truly identifying quality issues when they are occurring so that they are accurately reflected in the documentation and the data? That's going to be a big challenge for the healthcare industry. And I think it's going to take us a while to get all of this figured out. Because remember, we've got to have the strict specific documentation most of the time when we're dealing with complication codes. So organizations need to be careful to avoid discouraging CDI staff from querying when it would cause a negative quality metric. We want to be as ethical and as transparent in this process as possible. And providers need to be held accountable to ensure accurate documentation is there when a complication or adverse event has occurred so that it can be accurately captured. So I'll kind of jump off my soapbox now. I think I've made my point. And at that, Brian, we've moved to our next poll question.
Okay, great. Thanks a lot, Cheryl. Just as a reminder to our audience, you can select your answer at any time while I'm reading this question. So you can see it in front of you, but it reads, is your CDI staff involved in the identification of cases with PSIs? Please select one of the following. Yes, no, it's in the planning stages, or I don't know. Once again, is your CDI staff involved in the identification of cases with PSIs? So once again, Cheryl, while we're gathering some data from our audience here, just want to gather your thoughts on, and I know you're going to get to this later on, how CDI can be involved in quality measures, but without it overwhelming their job or taking on responsibilities traditionally handled by a quality department. You know, the whole productivity piece and how that affects the traditional quote-unquote CDI role. Do you have any thoughts on that?
I do, Brian. I really think it's important for every CDI department to know what their mission is. I think a lot of CDI departments have said, well, you know, our focus is quality, 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 and that's a very noble endeavor. However, there's a lot of times that we can affect quality or accuracy of documentation, but we don't ask those queries because it's not going to affect reimbursement how we want to, or for some other reasons because we don't have the time and so forth. So I think first and foremost, we've got to have a clear mission of what is the role of CDI. Secondly, then, if their mission does include quality metrics and making sure the documentation supports them or so forth, how do you measure their success? See, the problem is a lot of times CDI departments are judged on their return on investment, and so if you need to have some kind of way then to measure are they doing a good job or not, especially if the focus on quality then takes them away from focusing on other things. So maybe the case mix index drops, or the CC-MCC capture rate drops, or physician query response rate drops. So we just want to make sure that everybody knows what the responsibility is, and then how do you know what success looks like.
All right. Well, here's your results, Cheryl. We've got about a third that are involved, and another 16% are in the planning stages. But it looks like more are not than are. 38% say no. Does this surprise you at all? Any thoughts on these results?
Well, I'm guessing the third that is involved was the same third that knew what PSI 90 was. And actually I'm really surprised that a third of CDIs are already involved, because another one of my little pet peeves is CDI departments are usually understaffed in my experience, and they're being asked to do more and more with less and less. And so that can make it really challenging. I think the other thing that administration needs to be aware of is there's a lot of quality measures associated with obstetric cases, and CDIs traditionally aren't involved in the obstetric population. They're just not a good fit for Medicare reimbursement. The MSDRG system doesn't work well for them. So I think it is interesting. It would really be interesting to know how involved are they. My big push then is I'd rather see people in a collaborative role with it. So we'll go ahead and move on with the presentation then. And it's important that CDIs understand what is included and what's excluded, so that we're able to then know how to best help the organization to accurately represent what's going on. And so efforts need to be made to make sure that cases are appropriately excluded when they should be. And one of the ways that you can do this is through the coded data, because that's what these claims are based upon. So inclusion cases then, if you identify somebody that's going to fall into a population, those could be referred to the quality department, who could then evaluate to see whether or not the quality measure was met. I'd really prefer that it's not the role of CDI. Again, I think there could be some muddying if CDI are now commenting or judging the quality of care rather than just asking for clarification about things. So my best case scenario would be if you actually have the CDI department identify that they're potentially in a population, so that then the quality department can follow up and see whether or not the measures are being met or not, or is there an improvement opportunity for the organization. So I'd like to see collaboration between the two departments. So let me give you an example then. We're going to look at these individual these individual PSIs, and the first one that composes PSI 90 is PSI 03 pressure ulcer. And a lot of CDIs have already been aware of the role of pressure ulcers because they've been a traditional hack. If you didn't have a pressure ulcer present on admission and the person develops a stage 3 or a stage 4 pressure ulcer and it wasn't present on admission, or no pressure ulcer was present on admission, then you don't get the additional MCC from it. So we're familiar with it in that sense as a hack. But the hack reduction program is different from the traditional hack program, and hospital value-based purchasing is different as well. Again, it's beyond the scope of this call for me to get into great detail about the methodology for those two types of quality measures, but I do want to point out that hospital IQR, which is where the quality department was abstracting data for these PSIs, that was just based on whether you reported the data or not. The performance wasn't an issue. When we're looking at hospital value-based purchasing and the hack reduction program, these are going to be a comparative measure. How do you compare to every other hospital in the country? So some hospitals are going to be huge winners because they're already involved. That 1/3 that already has their CDI department aware of this and involved with this could end up doing better on these metrics just through awareness and monitoring compared to those who aren't, because it's a comparative thing and the results are comparison. So looking at PSI 3, this has to do with pressure ulcers, and if stage 3 or stage 4 pressure ulcer is a secondary diagnosis. It doesn't matter whether it was present on admission or not. That's not part of this calculation for a PSI. It's whether or not there's a stage 3 or stage 4 pressure ulcer as a secondary diagnosis. So this is just a little reminder on here that you've got two codes in ICD-9 when you're defining a pressure ulcer, one to identify that it is a pressure ulcer and its site, and then a second code to identify the stage. Remember that the staging can be taken from other clinicians as long as the diagnosis of pressure ulcer has been made by the provider. What I want to make sure you're aware of, though, are the exclusions, because we want to make sure that we're accurately identifying cases that should be in the population versus should not be. Okay? So one of our exclusions is if their length of stay is less than 5 days. That's a huge exclusion, because if you think about it, it should be less than 1/3 of your hospital admissions that are there longer than 5 days. So you want to make sure that there's accuracy in your admission, discharge, and, in your admission and discharge dates. A lot of times these are just computer generated within an organization, and so when they're registered, that's the admission. So if somebody comes in at night, make sure those dates are accurately so you're not automatically rolling over to a next day when you shouldn't be, and so forth. Also, if the pressure ulcer is the principal diagnosis, then the case is excluded. So if they're being admitted for the purpose of the pressure ulcer and it was likely present on admission, that's a way to exclude it. So make sure the principal diagnosis is accurate when there's pressure ulcers involved. The other thing to look at is that if the patient has a pressure ulcer that is present on admission, so that's a way that you're out of the sample. Or if the person is hemiplegic, paraplegic, or quadriplegic. That excludes them from this population. So you'd want to make sure if the physician's documenting left side weakness that you have the diagnosis associated with that, as well as spina bifida or anoxic brain damage. And then transfers from another facility exclude them. One thing that we take for granted is that we have accurate data about how people are coming into our facility. And so if they're from a nursing home or other locations, that's going to exclude them. So you don't want to take negative credit for something that belongs to another facility. Make sure you have the stuff accurate. So the other thing that excludes you from this is if you have a population where the principal diagnosis goes to MDC9. When we're looking at MSDRGs, we've got our different body systems, which are called MDCs. So if any of the diagnoses is going to map that to a DRG in MDC9, which is diseases of the skin, subcutaneous tissue, and or breast, or MDC14, those cases are excluded, as well as if they're a case for surgical debridement or pedicled graft. I'm going to pick up my pace here just a little bit because I'm kind of noticing that I'm getting a little tight on time. But the next PSI, remember there's only 8 that are included for the CMS metrics, is iatrogenic pneumothorax rate. And I think this is one that's already been on CDI's radar. You don't see these occur very often. There's not a lot of issues of it, but I want to make sure that you recognize that the code for iatrogenic pneumothorax is 512.1. It's not the same as postoperative air leak. That would be 512.2. So make sure that documentation is clear. Are they describing a postoperative air leak or a iatrogenic pneumothorax? And it's defined by coding as air trapped in the lining of the lung following surgery. But coders cannot assign this code 512.1 based on radiological findings alone. Remember, we have to have an associated diagnosis from the physician. And the documentation needs to clearly identify, was it present on admission or not? Because if that pneumothorax was present on admission, it excludes it from the population, and that's a good thing. We want to exclude them when they're appropriate. Other things that can exclude them is if they have an ICD-9 diagnosis code for chest trauma. Now, if somebody has chest pain and they were in a car wreck, you can't assume that chest pain is traumatic. The person has to specifically say it is a traumatic chest, the physician has to specifically say it is a traumatic chest pain. Otherwise, it would go to chest pain other, and it's not going to exclude it. Pleural effusion is another thing that excludes it. But keep in mind, if somebody is admitted with heart failure, then pleural effusion isn't going to be coded. You have to go to the heart failure as the principal diagnosis if it would have otherwise been pleural effusion. So that might give you problems with cases not being excluded when they should have. And then certain procedures, if they're coming in for thoracic surgeries, diaphragmatic repairs, and so forth, are going to exclude them, as well as MDC14. So the next PSI that's in the composite of PSI 90 is central venous catheter-related bloodstream infections, and that's a mouthful. What we typically think about when we're talking about central venous catheter-related bloodstreams is our Class Bs. So if we have any of these as a secondary diagnosis, the codes that have been effective since October 1st are 999.31, other and unspecified infections due to a central venous catheter, or 999.32, specifically a bloodfection due to a central venous catheter, which is your Class B. So the documentation needs to clearly identify if there's a central venous catheter that caused the infection. There has to be that cause and effect relationship. But if it was present on admission, so it's the principal diagnosis, that would exclude it from the population. If the length of stay is less than 2 days, the case is excluded. So those short stays. if the case has an associated ICD-9 diagnosis for cancer. Now I do want to mention, when I say an ICD-9 diagnosis for cancer, you may be saying, what is that code? There is an appendix if you go to the AHRQ site, or it might actually be on the QualityNet site, where you can look up the ICD-9 table of codes that are considered codes associated for cancer, or procedure codes for an immunocompromised state, and then that way you'll know exactly what codes are the ones that are going to exclude someone. But it's a large list of codes, and it was going to be too difficult for me to include those. But certainly if you have a patient with any kind of history of cancer, then you're going to want to make sure, is it truly just a history, which means they no longer have it, or do they still have the cancer? It's a chronic condition for which they still occasionally receive treatment, monitoring, and so forth for it. Because a lot of times when we see history of cancer, we don't know whether they still have it or they no longer have it. So the next PSI that's part of PSI 90 is postoperative hip fracture rate. And this is one where, again, we need to see, whenever we're coding a hip fracture, we need to know, or fracture in general, we need to know the cause of it. So these are very specific codes that we're looking at for postoperative hip fracture. It could be 820.0. The reason why there's an asterisk there is that fifth digit could vary. Same thing with the 820.1. There's an asterisk because it can vary as to whether it's open or closed and so forth. So the next few slides will show you the types of codes that are then, if they're the secondary diagnosis, would end up leading to this PSI 90. So you want to make sure that those fractures are accurately coded. Also, whether it's the principal diagnosis or not, because if patients admitted for this, then they're going to be excluded. It also excludes cases with diagnoses that are susceptible to falling or trauma. And look at the huge list, things like syncope, stroke, occlusion of the arteries, poisoning, delirium, things like that. All of those things could exclude these cases. Ever heard of a patient that was a little confused? They had their side rails up, they didn't know where they were, they tried to climb out of bed, they fall. Make sure you have the diagnosis that actually reflects what's going on with the patient, so that people are accurately excluded when they should be, but then you also can capture quality issues when they do occur. So cases with self-inflicted injuries are also excluded, but keep in mind these are reported by E-codes, and E-codes are voluntarily reported, which means an organization isn't required to report them. And then you can see that MDC-8, so your DRGs that go to MDC-8s would also be excluded, as are the MDC-14. And that's pretty much a general thing that we're going to see with MDC-14. So PSI 12, postoperative PE or DVT, is also part of the PSI measure. And so these are going to be codes that are assigned to Category 451, so it's phlebitis or thrombophlebitis. And this is defined for coders as an inflammation of the vein, which is the phlebitis, or formation of a thrombus, which is the thrombophlebitis. And coders would assign additional code then if it is a thrombosis. So the documentation needs to clearly identify if you're dealing with a pulmonary embolism or a DVT. If it was present on admission, again, that would exclude it. And make sure that you have it coded accurately. There's specific codes that puts you in the inclusion population. So if it's a phlebitis and thrombophlebitis of the deep vessels of the lower extremity, that could go to a different code. Or the iliac vein, you want to know what includes versus excludes somebody from the population to make sure the documentation is as precise as possible. Also, the procedure code of 38.7 is also affects the PSI 12 reporting as well, and cases that go to MDC 14. Postoperative sepsis is PSI 13, and it's another one of those things that contributes to our PSI 90. And so this is when any of the following ICD-9 codes occur. And I purposely listed these out because I want you to notice how many different codes there are. So if somebody's being very specific about the type of sepsis, so they tell you that it's E. coli septicemia or something like that, or they just say sepsis or organism unspecified, there's a lot of codes that's going to put them into this postoperative sepsis. But sometimes we don't have the accuracy of documentation or the sensitivity to know were they septic before surgery or after surgery, because they could have been not septic on arrival, come to the hospital, develop sepsis, then had surgery. So sometimes we're going to see that there's a problem with the indicators and lack of sensitivity in ICD-9, as I discussed earlier. But some of the exclusion codes, again, is if they were admitted with sepsis or an infection, a length of stay of less than 4 days, MDC-14, and then that diagnosis codes for cancer or procedure codes for an immunocompromised state. Postoperative wound dehiscence is PSI 14. This one isn't really easy for us to impact a CDI because it's all based on a procedure code. So either that procedure occurred or it didn't. And it's probably very rare that that procedure does occur. But you can see here then some of the exclusions are similar to what we've seen with some of the other cases. And the last one is PSI 15. And this is your accidental punctures or lacerations as a secondary diagnosis. Again, these are associated with E-codes, and these are voluntary codes, so not everybody is going to report these in the same way. We also know, especially because I used to work for an academic medical center, that there's a lot of variation when people do report accidental puncture and lacerations. That 99.82 code, there's a lot of variation in when people report it versus when they don't. The good thing in ICD-10 is that we will have a code that we can report it when it's not a complication. In ICD-9 it's always going to be a complication, but whether or not you report that code, again, like I said, there's a lot of variation. So one of the things that you can do is make sure that you understand what excludes somebody from that population. So because 998.2 is a complication code, that means that the guidelines apply that the provider has to document a cause and effect relationship between the puncture and or laceration and the procedure, as well as an indication. It's not that they have to call it a complication, there just has to be an indication. And then they would give an additional code to give further specificity about that. So the documentation, we want it to clearly identify when the accidental puncture or laceration was present on admission or not. And then cases with any listed ICD-9 procedure codes for spine surgery are excluded, and those with MDC-14, as we've seen with many other, are also going to be excluded. So our patient safety indicators are an example of where both principal and secondary diagnosis codes can indirectly affect reimbursement because of the 3 different quality initiatives. There's the inpatient quality reporting, hospital value-based purchasing, and HAC reduction program. And as is the case with many other quality measures, you can get hit with PSI 90 penalties 3 different ways. And the scoring is different in each of these 3 different ways because the software might be different, the timeline might be different, and so forth. So it's going to be very difficult for organizations to quickly get a handle on the impact of PSI 90 and other quality metrics. But this was just to give you a taste of PSIs and how it affects quality. So Brian, that was a lot of information in a short amount of time.
Great. Thanks a lot, Cheryl. Great presentation today.
Thanks.
We're going to try to get to some of these questions that we've received throughout the program, but I just want to remind our listeners that we are recording this program and that we will be posting the recording hopefully by the end of this week, if not early next week. And that will be on the CDI Week page of the ACDIS website, and there's a tab at the top. That is the resources page. I'm sorry, the toolkit page. So you will see there are past recordings of 2013 and 2012 CDI Week programs that will also be posted to that page, the recording of the show as well as the video files. So I hope that answers some of those types of questions. So maybe we'll start, Cheryl. I mean, there's a number of questions in here. You know, one of them I thought was interesting is, you know, the person asks, shouldn't CDI place a PSI-related query rather than quality to ensure query compliance? I mean, this is sort of the handoff piece. How would you explain that, Cheryl?
I think that is an excellent question. And again, it's one of those sticky kind of situations. And I think it really depends on the organization. I don't like to do a one-size-fits-all because I know every organization is unique. But I agree, if the quality department is going to be querying, basically asking for clarification of documentation, then they need to adhere by HEMA's guidance and CMS guidance and so forth, because the HEMA guidance clearly says regardless of what your role is, if you're querying, then you need to abide by their guidance. The thing is, though, is I hate for CDI for their productivity, if you will, to be diluted. And so you want to make sure that the metrics reflect what you're doing. So it always bothers me when CDIs are graded, if you will, on things like what is the CC-MCC capture rate, what is the case mix index, because case mix index in particular is such a huge, broad measure. So as long as the way they're evaluated reflects what their daily work is, then I have no problem with CMS reflecting quality. I think it only becomes challenging when they're still measured on, say, reimbursement type metrics, but then they're spending a lot of their time doing quality-based queries. Then you're going to have that disconnect, and the CDI department may not get the credit for the impact that they're having. So I do agree that CDIs are often more skilled, but what I might suggest is you have a second level kind of process involved where only certain CDIs or a dedicated CDI who works collaboratively with the quality department is involved, so that hopefully there's some reviewing of the coding process and the documentation first before that query is issued to make sure everybody's on the same page. Because I know in my previous experience sometimes people would jump the gun and then would realize, well, here's how come it went that way.
Yeah. Okay. Thanks, Cheryl.
Mm-hmm.
This next one is sort of a detailed question about, the person's asking when would a postoperative hip fracture be a complication, or when would it be concluded in post-op? Any examples do you have of that, Cheryl?
Well, see, the problem is there's not really a way for them to identify it as postoperative. As surgery occurs, then that's going to be, so they're looking for a procedure and they're looking for that code. And so it couldn't have been present on admission, the hip fracture, otherwise it wouldn't have been related to postoperative. But that's what we mean by the lack of sensitivity with this, because they could have had that hip fracture and then gone to the surgery and so forth. So I think there's going to be some growing pains until the code set is sensitive enough or reflective enough, which means there's probably going to have to be some negotiation, but it needs to be ethical and transparent negotiation so that we are identifying when these things happen. See, for the HACs, the current HAC program, if it wasn't present on admission, then it's a penalty. Whether it's postoperative or not. And so I think that calling it postoperative, there has been some discussion from AHRQ about renaming some of their measures. For example, like the postoperative DVT and PEs. They're talking about maybe they need to rename that one because, again, it's not sensitive just to postoperative. And just to give a little plug for something I've been working on is the what we're currently calling the Advanced CDI Boot Camp. And we're going to talk a lot more in depth about these types of quality measures because we're seeing a lot of interest from not only CDI departments but other people as well. And the name's a little scary calling it Advanced CDI, but the reason why we titled it that is because it's talking about these next level things. And so it's not really geared for the day-to-day of what a CDI does. It's thinking about, okay, now we've reached our threshold in reimbursement. Where else can we go? How else does coded data impact things in our organization?
It's a great point, Cheryl. We are, as you probably heard, for those who dialed in early and heard our pre-program lead-in commercial, this is going to be a small component of our Advanced CDI Boot Camp that is coming out later this year, and quality metrics will certainly be a component of that. Cheryl, this question came in earlier in the presentation, and it reads, since AHRQ has 11 PSI measures, and you mentioned that CMS is using 8, do you know if all 11 will be publicly reported on the AHRQ website, even though they don't have a financial impact?
I think I'm understanding this question. It's usually Hospital Compare where the metrics are posted rather than AHRQ. And what it is there's many measures that are a subset for IQR, the Hospital IQR, which is what we've been reporting for several years, and that gets posted to Hospital Compare. The thing is that IQR is slowly phasing out a lot of metrics. Like I think they've already phased out heart failure discharge instructions, but it's taken a year or two for the rest of the CMS quality initiatives to catch up. So if you go to the QualityNet page and you look on a specific measure like PSI 90, it'll tell you whether it is CMS voluntary or whether it's IQR voluntary or Joint Commission voluntary or so forth. And then that will give you an indicator of whether or not it's going to be reported or not. So I don't know for sure, but I do have an understanding that CMS is trying to eventually get everything to coincide. It's just going to take a while to get there.
Thanks, Cheryl.
Mm-hmm.
Another interesting question here. It says, when the documentation is subjective and our PSI team, which consists of coders, CDI, quality, and the provider, disagree on whether or not a PSI exists, is it okay for coding to change the code based on a decision made rather than clear documentation clarification since it's subjective, or does this open us up for an audit?
Wow. I think that here's my personal stance. If you look at the coding guidelines and you look at any coding clinic advice or anything like that, it clearly says that codes can only be based on the associated documentation. Also, for Coding Clinic ICD-10, there was one that was talking about how you can't have local policies within your hospital that are different, that disagree with the coding guidelines and coding clinics and so forth. So you can't supersede what's officially out there. So I would be very concerned and think it would be vulnerable for an organization to make an internal decision not to report something or to report it using a different code than the documentation supports, because coding should really be kind of independent of this process. And what I mean by that is the documentation is the documentation, and whatever code that goes to, then that is what needs to be coded. One of the reasons why we're seeing this movement towards CDI involvement is, as I was mentioning, abstracted data usually occurs 60 to 90 days out. And one of the hidden things within the quality metrics specifications manual is that you're not supposed to be querying or changing documentation for the purposes of passing a quality measure. And so if you're querying them 60, 90 days afterwards, that's very problematic, which is why we're seeing people move it to concurrent time period, which is why CDI is involved. Let the coders do coding. Let them be independent. Let there be kind of a Chinese wall, and so that the documentation is either there or it's not. Where you have an impact is in working with the provider, that they either provide the documentation to support what code is going to be reported or not reported, that the documentation is accurate, and if there's an issue, then that's where you call in your second level process of maybe the medical executive committee or somebody like that. If you have a physician who refuses to document something so that they're not penalized when something really has occurred.
Interesting.
Yeah, it's going to be scary, for coders and everything. This is getting into a huge gray area and a lot of ethics, and we have the ACDIS ethics and AHEMA ethics and things like that. But I think there would be a lot of vulnerability in changing a code without the documentation to support it.
Yep, that's a good point, Cheryl. All right, maybe we'll just take one more question. We are a couple minutes past the top of the hour. I know we got a lot of them in, but let's take a look here. Cheryl, someone had asked if what effect, if any, does the palliative care code V66.7 have on quality measures? I know that's. I don't know if that's in the formula or not.
I do like this question, and I like it a lot because this was something that we struggled with, 4 years ago when I was still at the hospital setting. The thing about the palliative care code, V66.7, is it's too nondescript. And I worked in hospice a long time ago, believe it or not. And the thing about palliative care is people actually tend to do better when they have palliative care because there's the coordination care and they're taking off all the medicines they don't need to be on, and anyway, so on and so forth. But the thing that can pull you out of some different measures for IQR, inpatient quality reporting, is if it's comfort measures only. That's an abstracted term, not a coded term. So the abstractors would be looking for the phrasing comfort measures only, and there's a few other terminologies that they can use, but the V code, V66.7 itself, does not have a bearing. So to my knowledge, none of the administrative claims, so the things that I was talking about where they're based on coded data, none of those use V66.7. When they're abstracting the data, though, they are looking for comfort measures only, or the same. There's a few limited terms that they can use to exclude them from different populations.
All right, Cheryl. Great. Thanks for that explanation.
You're welcome.
So at this time, we have run out of time for questions, but I'm just going to be reading a little bit of closing information about the show. We want to know that your feedback is very important to us. Shortly, the person who registered for this program will receive an evaluation link, which we hope will be distributed to all who listened in your group. We would appreciate it if you could complete that evaluation at your earliest convenience. As a reminder again, this program does offer a CCDS credit, and if you're interested in obtaining it, we ask that you please download the instructions from the Handouts tab on the left side of your screen. And I'm just going to conclude by saying I'm thrilled to have Cheryl here today to help sharing her knowledge on this very important issue. I want to remind folks that tomorrow we are offering a free Optum webcast on natural language processing and how some of this new technology is transforming the CDI profession. And you'll also be getting, of course, your next special Q&A e-newsletter. And once again, happy CDI week, everyone. We hope you have a great rest of the week and have some fun as well. So at this time, Chery, this does conclude our program, so back to you.
All right, thank you very much. And this does conclude our program.